The speakers in this session highlighted recommendations related to ensuring social connections and building protective factors for populations at risk in Vermont, the need for statewide agency-level coordination and support for in-state responsive calls to the lifeline, and strategies that address lethal means restriction. We've learned from past quarantine and public health emergencies that the conditions we've experienced with COVID do affect mental health of children, healthcare workers, older adults, people with ethnic and racial disparities, and the general public. In December of 2020, Vermont EDs saw an increase in visits for suicidal ideation and self-harm from past years. We have a tremendous opportunity right now to support legislation that strengthens our systems and moves us upstream.
Loneliness has been a factor. I had a loss of a relationship due to COVID-19. I've experienced suicidality in the last year. But I got help. I called Vermont Support Line. I've called the Crisis Line, and they've all helped. I suggest that anyone that's suicidal to reach out and talk to someone. I've talked to pastors, I've talked to friends, I've talked to family. My mothers are good at support, and I work part-time, and I get out now. And I really appreciate the work that I've done with Laura. I really have been doing a lot better now that I've reached out to people and not isolated so much.
So how do we build connectedness? So there's different ways to do it. And I divided this up here in terms of sort of two main blocks. One of them is thinking about the individual and the family level. How can we build, if we're working with a single individual, how can we develop that sense of connectedness with all the people that often is around them, or building more people around an individual. And then, of course, there's also connectedness that we can have on the community level and on the proverbial systems level. And these two are not mutually exclusive. I think, most of us would agree that it's not or. We want to build connectedness on both of these levels and help individuals find their individual connectedness to family members and other people, but also to have these more large-scale supports and services that can help. What are other things that we can do on the system and community level to help build that sense of connection and support? And this is where groups like the Vermont Suicide Prevention Center and You Matter and Zero Suicide all really come in and feature really prominently. There are a number of things that we can do that can really make a difference. And that includes educating people, especially those in gatekeeper roles. So people like teachers and primary care physicians and caregivers to learn, about suicide prevention and how to respond when people express them in the most effective way. There are, having support for these lifelines, the upcoming 988 line and other lines that really are so crucial when people are experiencing a crisis and need some immediate support. And then also training our health and our mental health professionals about, evidence-based methods.
Social connectedness is very key to a lot of issues actually having to do with older adults, and suicide risk is among them. And that doesn't seem that hard to understand when you think about older adults. It's typical that they're losing relationships. Some of their family is dying, their spouse is dying, and they've, lost their job, and they don't have the meaningful role that they once had. For the last 15 years, for older adults, the rate of suicide has increased 16%. The most recent data I have is actually from the years 2017 to 2018. And during that time, nationally, the rate of suicide among older adults increased 6%, just from 2017 to 2018. But from Vermont, it was even worse. It was 11% increase in the rate of suicide for older Vermonters, 65 and older, during that period of time. And that was the greatest rate among the 50 states.
Our LGBTQ youth are not all right. And when you compare their health outcomes to their heterosexual and cisgender peers, the contrasts are stark. They're twice as likely to be bullied, 2.5 times more likely to skip school due to safety concerns, 2.5 times more likely to feel so sad or hopeless that they stopped doing activities. We know these disparities have only worsened. We do know what helps, and we need population-specific support right now. We must coordinate efforts to create brighter futures for LGBTQ youth, diminishing the social isolation that rural youth face as the only one like them in their class or in their school. It's helping family members move through their own journeys to lessen the devastating impacts of familial rejection that we know is such a devastating risk factor.
And when COVID hit, we knew that folks with disabilities, we know these numbers, that 5% are more likely to report suicidal thoughts, and 20% of folks who died by suicide had a physical health problem. And so we reached out to our community and we sent out a care package, a really simple care package with a little note, "We're thinking of you," that sort of thing, piece of chocolate, some PPE, and the amount of responses was overwhelming. And the one that got us the most was that a woman who just didn't think that anybody cared about her anymore. It's simple as that. It's the community connection part.
There really is a need for a more unified and systematic leadership structure to help connect the dots on what is working and what appears to be promising practices. With the support from the Vermont Department of Mental Health, Northwest Counseling and Support Services, our crisis service has actually been responding to the National Suicide Lifeline for Vermont callers across the state, anybody who has an 802 number. We've been picking up for about 48 hours currently during the weekend on some weekend hours. We really do see the value of a Vermont provider picking up calls from Vermonters and really kind of knowing the resources, knowing how to push our own systems and kind of get others to kind of respond if someone's not responding, or how to identify some resources versus an entity picking up in another state who really doesn't understand our resources. We're seeing a lot of activity on the National Suicide Lifeline, particularly with COVID, and hearing from individuals who have lost their jobs and feeling even more isolated on top of other risk factors. NCSS, or Northwestern Counseling and Support Services, we have been one of the first pilot sites for zero suicide a few years back, and we really do see the value of this model. It really does creates a strong framework for how to kind of approach your own system. So we're looking at our own system as a designated public mental health agency, but we're also engaging with the other systems in our community. And most importantly is really looking at what are the pathways to care, and we really need multiple pathways to care. And how are we continually looking at improving our systems?
We actually can't predict the suicide mortality rate. What is most predictive is how easily accessible firearms are. And I think that letting that sink in is really important. We have a higher than average suicide death rate in this state compared to other states. And many folks think, okay, why is that? I've heard people say it's cold here, it's dark here, it's can be isolating. And really what researchers find is it's the firearm piece, the access to firearms, that can drive that disparity between states. That's true of the entire population of Vermont. It's also true of just young people, which is the data I know best. And that is that we also have a higher than average youth suicide death rate, also due to access to firearms. The social norms about talking about firearms, talking about safe storage is really important. We know that preventing suicide is all about changing societal norms, right? It's destigmatizing mental illness. It's encouraging access to mental health services. It's providing access to mental health services. Reducing bullying and cyberbullying, and talking about firearms and talking about safe storage and potentially temporarily removing firearms. All of that needs to be part of the way we talk, and it needs to be done in a non-judgmental way so that we can be very open and create some change around this.
At the national level, when we look at mental health disparities, we know that African American youth are less likely to receive professional assistance for depression and less likely to be referred by the school system for mental health services. We also know that Black children, Black, Indigenous, and Latino children nationally have 70 to 75% less are less likely to receive supports for mental health services compared to white children. So what does it look like in Vermont? These disparities continue in a state that is predominantly white. In Vermont, we know that Indigenous people in 2015 were diagnosed with depression at a rate 1 in 3 compared to white Vermonters. And Native American youth have the highest suicide rate of all racial and ethnic groups in our state and nationally. Young people who are racial or ethnic minority are more likely to make a suicide attempt that requires medical attention compared to white youth. Do suicide prevention training should look like? They have to incorporate content related to systems of oppression and the root causes of trauma, disparities in underserved communities. We need providers training that include structural competency, systemic racism, and intersecting isms, classism, ableism, heterosexism, sexism. And providers must engage in critical reflection about their work with historically underserved communities.
I think we do have to move upstream and normalize a discussion of mental health and how different populations are affected by mental health challenges. This means building communities and systems of care that are responsive and helpful.